Eczema affects approximately 1 in every 5 children worldwide, making it one of the most common skin conditions in pediatrics today. Its impact on children's quality of life and the search for effective treatments remain at the forefront of dermatological research. Our guest today, Dr. Lawrence Eichenfield, Chief of Pediatric and Adolescent Dermatology at Rady Children's Hospital and Professor of Dermatology and Pediatrics at the University of California, San Diego, is a leading authority on pediatric skin conditions with a deep specialization in eczema. His groundbreaking work in the field, including his insights into new treatments like crisaborole, I think I screwed that the way I set it up, but Eucrisa, has been instrumental in advancing our understanding and management of pediatric eczema. Today, we'll explore the safety and efficacy of emerging treatments compared to traditional options and what parents should consider when navigating these choices for their children. So it's a real treat to have Dr. Eichenfield here today.
Thank you so much for having me.
So, Dr. Eichenfield, could you please start by sharing the latest advancements in our understanding of pediatric eczema and how this knowledge has influenced new treatment approaches?
Well, it's been really an incredible decade with amazing advances in our perspectives on atopic dermatitis. And this includes our understanding that the course of atopic dermatitis or eczema is so variable. We have young children, infants who have eczema, who may have mild eczema and may outgrow the disease within a few years. That used to be the core message that we gave to families, but then we really recognize that there's a lot more inconsistency with that. There's both infantile eczema that can stay on into adulthood. There's later childhood onset and adult onset eczema. There's an understanding of the sort of immune basis of eczema. There's been an increase in eczema. So compared to 30, 40 years ago, we had a 5% prevalence, meaning 5% of people had eczema. Now it's up to 15%, 12 to 15% of children in most of the industrialized world. But probably the biggest thing is that with a lot of work, pairing people with an interest in eczema with companies and convincing companies that there was a lot of clinical need, we have a real expanded set of medications, both systemic medications and topical medications beyond our traditional topical steroids that really help us to manage eczema in a very different way.
So you mentioned that the prevalence of eczema or the incidence of eczema has really increased. It sounds like it has nearly almost doubled. And I'm sure that some part of that is because of education. We understand it better. We have more research going on behind the scenes. So, but what do you think is contributing to this increase?
Well, I mean, I'll translate that to the question is, why is there more? And what are the factors that make more eczema as compared to the past? I don't think it's just that we recognize it more. It's really complex. It's probably a mixture of the changes of the immune system and what it's exposed to in early life in our modern world. We have less parasites and less worms, and maybe that part of the immune system isn't busy doing that stuff and it's revved up to do other stuff. So that's part of the immune changes. Also, there could be, the environmental exposures, air pollution, how much we clean our skin. Maybe we're overstripping our skin cleansing, which exacerbates natural tendencies to have skin that's a little more open, that gets sensitized. So it's probably really a mixture of factors beyond just the genetic factors that give us more eczema in young kids. And then having the 7% prevalence of eczema in adults means that things are a little bit different there as well. And it may be a mixture of those factors just persistent.
So it sounds like epigenetics may play a role here.
Absolutely, yes.
So new treatments have come out like Zorvi, Adbry, just to name a few. How do you feel about the safety and the efficacy of these treatment options compared to the traditional ones that have been on the market for quite some time that we obviously, really trust and feel confident using?
Yeah. So I'd start off with the general sense that when you have an individual with eczema, whether that make it like let's make like a 22-year-old and a 2-year-old, okay? The general approach is that there's aspects of the eczema that relate to the symptoms. There's the rash of eczema, there's dry skin, and more open skin that evaporates the water from the skin, which makes it dry. There's this tremendous itch, and the itch is exacerbated by open skin, dry skin, and then inflammation, which manifests as the rash. It could be dryness, crusting, oozing, and they cycle together. And our therapies, for very mild disease, you can just do moisturizer. But when you have inflammatory rashes that outstrip good quality moisturizers, then you need anti-inflammatory medicines. And basically, there's the topical agents, which we can come back to, which traditionally are topical steroids, but now we have an expanded set of non-steroids that sort of work like steroids. And then there's the systemic medicines, some of which you had mentioned. And there's been an incredible breakthrough. Historically, our systemic medicines weren't used that much because they were very immunosuppressive. They suppressed the immune system. And so they created problems with concerns about serious infections, cancer with long-term use. One of them, not even long-term, cyclosporin was an effective drug, but you didn't use it longer than a year because it increased rates of cancer. That sort of made it not be used very much, especially in children. And partially because those drugs, my analogy to patients is like I want to turn off the inflammations as selectively as possible. Like I want to turn off a lamp in apartment 3C in a building down the block. And like oral steroids or cyclosporins, that's turning off electricity for the whole house, or maybe the whole apartment house, or maybe the whole block. It's turning off that lamp, but it turns off a lot more. And now we have much more selective switches. And some of those are injection medicines that turn off little switchers that are important in the type of cells that create the inflammation of eczema. And drugs like dupilumab and tralokinumab, which are Dupixent and Adbry are the trade names. There's another one coming down called lebrikizumab. It'll be approved shortly. These are medicines that turn off relatively small switches that are important in eczema and highly successful in treating eczema, as well as in some cases like Dupixent also treats asthma and some other conditions, but they're fairly selective, and it decreases infections in the skin rather than increases infections. And the relative safety of these compared to our traditional systemic medicines like cyclosporin, oral steroids, or methotrexate, it's a different planet in terms of them being much more effective with much less trade-off of potentially negative effects.
Yeah, so the selectivity of being very specific has made them much more safe, thanks to research and science. How will you decide? So I hear you mentioned this new drug coming down the pipeline. How will you decide if someone is currently on, say, Dupixent? Dupixent has incredible results and outcomes. But they're still like, maybe they've been on it for a long time now and they're maybe tapering off and they're starting to see a flare of their eczema again. Would you consider at that point switching them to one of these new options?
Yeah, so I think that what it comes to is that every time, my job, right, as someone who spends a lot of time in the field, is to look at groups of people and data, but it still comes back to an individual decision with every patient. If a patient is essentially clear or fully clear or almost clear on blank, say Dupixent, we generally won't turn them away from that to something else, especially because the newer drugs, what we call the biologic agents, there's no evidence that extended use with the drug creates more problems. So it's not like 3 years of the drug compared to 1 year of the drug. You better move on to another drug because you're picking up these special side effects. Fortunately, they're not like that. So if someone's doing great, you leave them on it and or test if they really need to continue on it by maybe decreasing the frequency of dose or testing them off of it to see if their disease is sort of rebooted and they've come into remission. On the other hand, if you have someone who's like 70% better on a drug and you've given it an adequate time, then it's a question of like, is 70% enough, or do you want to try something new that may bring a deeper response or more penetrative response, as we say? And that can include either a different biologic agent, or there's also these oral medicines that are called oral JAK inhibitors that we have approved, 2 in the US and an extra 1 in Europe, that are different kind of drugs with different side effect profile, but highly effective and very quick at reducing eczema and reducing itch.
So what's your approach? You know, there's so many options now. There's the topical options, the oral medications, the injections. If you have a patient come in, obviously with mild eczema, I'm assuming the first thing you do is you're going to try a mild corticosteroid because you want to, you know, start slow and see if you can get some improvement. But if you have someone who's moderate to severe and the mother's like, I really, you know, once you tell them, or the parents, oh, we're going to have to do an injection, it's like, oh my gosh, I don't want to put a needle into my kid, which I understand. So what is your approach? Do you start with the oral medication? How do you go about it?
Yeah, so a lot has to do with how bad the disease is, how long the disease has been going, and what's been tried before, or if it's new and fresh. And also, it's very important because a lot of people have been taught to be very fearful of topical corticosteroids. And the problem with topical steroids is that I wish we had different names for the different topical steroids, because, you know, I write a little chart. There's like 70 different topical steroids. And the difference between over-the-counter hydrocortisone, and which is 1% hydrocortisone, and the strongest steroid that happens to be 0.05% clobetasol. So the number is way smaller, but that medicine is 2,200 times stronger. So the difference in concerns about it getting absorbed into the bloodstream and what the side effect profile are totally different in those drugs. But, you know, so a lot of people just get fearful of medicines in general, or fearful of topical steroids. And so what we have to do is figure out what's a reasonable amount of medicine that's going to not create any significant side effects and adequately control the disease. And you know, so if someone hasn't tried something before, but they've never used a topical medicine, I may start with a topical steroid low strength or medium strength and see if that gets it under control with a few weeks, without the plan to continue that forever. It's till we get to that and then see, can we get to just using medicines more intermittently, because that's what will allow us to avoid the side effects. On the other hand, I have this whole flock of non-steroids that are now greatly expanded, and in another year will be that much, you know, more of them approved. That gives us a lot of different choices to try to get the disease under control and keep it under control. But the takeaway is that for any patient, whether I'm thinking I can manage it fully with topicals or with the systemic medicines, I sort of want to establish the same outcomes, which is that I want minimal eczema, so the minimal rash. I want minimal sleep disturbance, because the itch keeps people up, and that affects all aspects of their work life, school life, or home life, and the life of the family as well. Because if you have a 2-year-old who's up all night scratching, you know, the rest of the family is probably up too. They cohabited the bed.
It can even affect the growth of the, yeah.
Absolutely. So if you go to, you know, minimal rash, minimal itch, and minimal sleep disturbance is what I'm going for. And that might be with topicals, or it might be that it makes more sense to move over to what we call the systemic medicines.
So what about the side effects? Like, what are the most common side effects, whether they're on a JAK inhibitor or a biologic?
Yeah. So start with topical side effects. A lot of the topical medicines sting. Especially our traditional non-steroids. So our first generation of non-steroids with tacrolimus and pimecrolimus. And then the next generation was crisaborole, Eucrisa. And they sting for, not in everyone, but in some people. And it can be a limiter if you have raw open eczema skin, you put it on, it's burning and people can't use it. Some of the topical steroids do as well. So sometimes that can be a limiter. And then Sometimes it's the side effects with topical steroids would be thinning of the skin if you did it continuously. So you just do that. You don't do it in that method to avoid it. And then other than side effects, there can be an annoyance factor with topicals. If you're having people smear stuff all over their skin twice a day with their medication and then moisturizers as well. There's the gooiness factor and also just the physical work involved. So that may not be a side effect, but it's something, there's a burden that can wear down on patients and families. For the systemic medicines, it's medicine by medicine. So the oral JAK inhibitors can increase the risk of blood clots. So if I have someone who's had a blood clot, I'm not putting them on an oral JAK inhibitor, with rare exception. And if someone who's 67 years of age, their chance of, they have cardiac risk factors, oral JAK inhibitors are be associated with a higher risk of cardiac events. Though a lot of that comes from a different set of medicines, really a different type of JAK inhibitor than the ones that are approved for eczema, but you still sort of do that risk assessment for each individual. So you have to do blood tests with oral JAK inhibitors to make sure that you're not having a negative impact on certain parameters of the blood. And they're taken by pills, not injections, so it's a trade-off for that. So each drug has its issues with it, but generally well tolerated, and those are discussions we have with our patients or families.
So, we know eczema is a chronic skin condition. And yes, there are those kids who may have it when they're young, and then once they start getting older and they reach into their teens, they can outgrow it and maybe it will come back later in life. What is the average period of time that you're finding that you need to keep someone on, the JAK inhibitors are newer to the scene, so they haven't been around as long, but the biologics, how long, like when the parents come in and they say, how long is my kid going to be on this medication? What do you say on average?
If you asked me 6 months ago, I'd be really clear, because 6 months ago I would have said, my standard is if I'm taking this change of life, we're going for a life change with, with a biologic agent, with one of the injection medicines, I'm going to plan on a year of treatment. I'll say, we'll sort of get a sense of how we're doing at 4 months. We're not really judging till 6 months. We'll probably go to a year because we get a lot more benefit with extended use with the biologic agents. With the JAK inhibitors, I might say, yeah, I'll plan on a year. We'll start to see response within a month. By 3 to 4 months, we'll know where we're going. But unless we're having a problem and it's not working well, we'll probably stay on it for a year. Now, what I say is a little different the last few months. Our new experience in babies is sort of mind-bending because Dupixent, Dupixent got approved down to 6 months of age. And there were not a lot of children under 2 around the world who had been treated with it before that because it was very off-label. And it's sort of fascinating that we have some really severe infants who aren't responding to topicals. They're getting better after 1 shot. If they come back a month later, because the shots are monthly, or 2 shots, and they're like 90% better. And it's sort of raised the question of, maybe it's not a multi-year treatment. Maybe, can I treat for 4 to 6 months and then pull it out and see if the immune system's rebooted or not? So one of the interesting things is that we know what we know at this point, but the experiences are always change our perspective as experts who spend a lot of time on this. But the general takeaway is that for most patients undergoing a biologic agent, it'll probably be 9 months to a year to get started, and then many patients will keep going for another year or 2. And you don't like to stop and start with biologic agents because there's a concern that because they're injections, because they're antibodies, and that you can't get them, then you can't eat them. You have to just put them in the blood, and that your body can make antibodies to antibodies if it only sees them now and then, and that might stop working, as compared to the oral JAK inhibitors, which are oral medicines, and someone could use them if they flare 3 months a year in the summertime, for instance. You could use them for 3 months and then come off of them and go back and use them as they need. So it really depends upon what the expected course of the disease is.
So there's more to be found out to find out if this is going to be an as needed treatment or more of a lifelong. Are you concerned at all about, I know we spoke about how these medications are becoming more selective in what they inhibit, but do you have any concern about the potential long-term side effects of JAK inhibitors or any of the biologics causing or reactivating like lymphomas? I mean, obviously, it's going to take years to really see that outcome, but I'm just curious if that's a concern at all for
Yeah.
you.
So this, I think there's partially it's like, what's my style of, am I ever not concerned
Mm,
versus am I concerned? And at what point am I comfortable using relatively newer medicines? And I think it's that I put it in that perspective. I'm an aggressive therapeutician, but I also have uh, conservatism, partially because I'm a dermatologist and a pediatrician. As a pediatric dermatologist, I'm double trained, and the pediatrician in me is, kicks in more cautious, and
mm,
kids are resilient and sometimes fix themselves. Um, so you know, the we keep looking at extended courses of data. In other words, the more the experiences when we're 7, 8 years into dupilumab plus a few years of clinical trials, and there's no signals about immune suppression or cancer or stuff coming up, makes us pretty comfortable. The JAK inhibitors are a little trickier because they're just different molecules, but their data sets at 5 years are looking very, very safe as well. But they're probably more concerns because the nature of that particular drug is that it hits more switches. It's hitting more circuit
mhm.
breakers in the house. So the question whether it's affecting something else may be a little greater. And so it's I can't say it's a moving target, but we can't have 15 years experience till we have 15 years experience. But we have a lot more when we're 7, 8 years into it after approval than we were 7 years ago, where we're just new to it. So I think that's no one would take any medicine nor get in the car and drive somewhere without understanding that there's some risk that's involved in our daily activities. And then I think good providers, healthcare providers, help their patients to assess the benefit and the risk. For severe eczema, many times it's like, if patients have failed topicals, and it's like, do you want to keep going like this? And their lives are so tremendously affected. And I'll have to say, on the other side of that, like just yesterday, had one of my follow-ups. This was a severe eczema patient I followed over 10 years, who,
Mm.
even when I thought they were doing well on topical medicine, we once had this event. I had the family come to talk to people who were training them about eczema. And I heard about all these workarounds, and like, they wouldn't take them to a field. They like to go on grass because grass would break them out. There were all these activities he wouldn't do because
Mm.
they were just fearful they would be eczema, it would stir up the eczema. And he's on long-term biologic therapy, happens to be with Dupixent. And, you know, he's like this, he's doing incredibly well. He's, doing these incredibly cool sports tournaments around the Southwest US. He's like out there in the world with no eczema to show, right? Because he's
He's a
fully
success
controlled. So
story.
yeah, yes, that's right. So I always take there are risks and unknown risks. They may not be that high, and then we balance them with the successes that we can get from the interventions.
Yeah, you always have to think about the psychological and psychosocial outcomes for children, especially. This is a time in their lives when they need to interact and engage with other children, also with their families. They don't want to be inhibited, like they can't go play on the field because the grass may flare their eczema. So that is
Yeah.
something that is very important to focus on. What are you most excited about in terms, you mentioned some treatments coming out. I would love to hear a little more about that and if you could share with the audience.
Yeah. So I think we're still processing our experience with our first set of newer medicines for the biologic agents, because dupilumab, Dupixent has been used for a variety of other conditions as well. We're starting to see secondary allergies that patients had that are being positively benefited by it. Patients who can tolerate foods, or I have several patients who are highly pet allergic, but now they pet sit for it's like
Mm.
really because they notice that they don't have a problem with it. So that sort of aspect we're working on. there's some newer medicines that are what I call a little higher up the food chain of inflammation that are in their core studies right now, which are called OX40 and OX40 ligand agents. And these seem pretty cool because you can give the medicine a few times, and they seem to go like half a year and longer without the need for other medicine, or with really good continued results without them needing topicals or other things. So the question of whether we can have sort of heavy hit medicines and then be off medicines for a period of time. And then the new topical agents, that there are these new non-steroids whose primary benefit is that they're not steroids, but that they're anti-inflammatory. Many are clearly stronger than some of our lower strength topical steroids and some of the other non-steroids we had. Many of them are really tolerable. And especially for like when we have eczema, it's very common to have eczema on the face, around the eyes. We don't like steroids there. They can thin the skin. There's occasionally these withdrawal phenomena that you have. And these new topical agents don't have skin thinning. That's not on the list. It's not one of the things. They work through different mechanisms that don't have that. So their more liberal use, I think, can really help a lot of patients to make their eczema much less impactful on their lives.
Do you think that that would be like maybe a first choice and once these come out?
Yeah, the first choice thing, when I'm consulting with companies, I don't fight for first choice because people are always going to push back and go, wait a minute, it's never going to be as cheap as a low strength topical steroid. So there's cost considerations as well. But I do think becoming a more reasonable parallel or quick second choice or alternative first choice if there's reason to avoid topical steroids is totally reasonable. And hopefully when I say the value proposition, the patients can get it and it's not incredibly expensive and it works to make them better. I think that there's going to be more of a move towards much more liberal use of non-steroids in regimens of care or taking over the care. Like there was a study on crisaborole that they took a bunch of patients who got better with the standard dosing, which is twice a day for 8 weeks. And then they rolled them over to like crisaborole every day or just, base like cream every day. And the most important part of the study is that it was done every day for a year in infants up to adults. And there was essentially no negative from it. There was no side effect profile that was any different from them just using the blank, and there were, it was longer time to flares and such. So that you would never do that with a topical steroid. So we can sort of, get this mix and match with what might be regular use of medicines or intermittent use of medicines. We have another medicine that's a totally different type of medicine to pin her off. It's an aryl hydrocarbon receptor agonist. So it's not a steroid, it's not a calcium inhibitor, it's not a phosphodiesterase, PDE4 inhibitor, just a different class of drug that has very good anti-inflammatory effects. Very little gets in the bloodstream. In psoriasis, it's been approved, and it can clear psoriasis and keep it clear for several months, where it gets this sort of remission in the area. And they've gone through their eczema studies, and they look quite good. Not approved yet at the time that we're recording this. So that could morph the treatment as well. So these agents are all going to be a little bit different in terms of what they can do, and that just leaves more possibilities for us doing better care that I think will bring a positive feeling that the stuff can work with less safety concerns, and then also with more tolerance. Because if you have medicines that sting or burn or that limits their use, it's nice to get newer ones where we don't have that.
And to top it off, medications that you can use for a long period of time without having, deep concerns. Do you ever find yourself using phototherapy?
So we use a lot less phototherapy. We happen to have, so I work at a children's hospital most of the time at Rady Children's Hospital, and we have a phototherapy unit there. It's called narrowband UVB. It's highly effective for eczema as well as for vitiligo and psoriasis. But for eczema, we use much less than we used to, and it's a mixture of two reasons. Like most places, our traffic isn't better than it used to be. Phototherapy essentially is 3 times a week for 12 or 16 week courses. So that's a lot of back and forth. Even if they're quick treatments, it takes a lot of time and energy. Getting home units where people will pay for a unit in the home, it's hard to do. That's a way of getting around the traffic. But because of both the logistics of it, and then of course you're getting light on, like it's like not quite getting a lot of sun exposure, but it's similar. But that's not without its issues. And the real issue is, so it's still highly useful, but we use less because when you give most people the choice of an oral therapy or injection therapy, which they can do at home, with probably higher levels of effectiveness and a good side effect profile, they're opting for that.
Probably also higher compliance.
Yes, because it's a lot. Yeah, even an oral pill or a shot every 2 or 4 weeks is a lot easier than 3 times a week coming in for, unless people happen to live right near a clinic, it's a lot of travel.
So I just want to end by asking you, because I get asked this all the time from parents, do you believe, we have all these amazing treatments, we have options, and it's incredible, really. If you think about it, the short period of time that all these eczema options have become available, will there ever be a cure for eczema? I've gotten asked this, and I have to ask the professional.
Yeah, no, that's okay. Before cure, I would like prevention. So the answer is that I do that. Where do we need more work, and where do we hope the next set of incredibly hard studies will be done to help us? And I do think that trying to do interventions that minimize the development of atopic dermatitis would be incredibly helpful for us. And there's still a lot about it. I spend a lot of time on eczema, and there's still a lot I don't really understand. Predicting who's going to outgrow it, who's not, what are the inflammatory triggers, why do food allergies so linked to it, yet they don't seem to be the drivers of the eczema directly in many of the kids. And then from a cure standpoint, with my newer medicines, and say medicine C, if I start that in a 10-month-old for 6 months, is that going to allow the immune system to reboot so that it changes their course of eczema over time and puts them in sustained remission or cure, as we say? We don't know that yet. The Dupixent got approved with very few kids being studied in 6 months to 2 years of age. So we're trying to get the groups together to do those studies. I'm very positive outlook. We're so much better than we used to be. We've changed the lives of so many people with our newer therapies, and it makes us, I think, double down in our commitment to try to work towards better prevention strategies and/or cures over time. And I think we can get there.
I do too, especially as the incidence of eczema grows over time. Well, thank you, Dr. Eichenfield, for joining today. I really enjoyed this discussion, and we're excited to see which treatments come available in the coming years.
Thank you so much. Pleasure to be part of this.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.